This is part 2 of fluid and electrolyte balance. So I skipped over the assessment and the behavior that you're looking at in the part 1 section because we're going to discuss that in this area. When we're looking at a young child for dehydration, one of the things you're going to elicit in the history is a decrease in the number of wet diapers. We have to ask the parents, are you noticing any tears when the baby is crying? And you need to look at this. In addition, look at the baby's mouth. What is the mucosa like? Is it moist? Are the secretions thin and clear, or are they more sticky and tacky? Is this child irritable? And the more dehydrated they get, they actually decrease their interaction and ability to be alert. They'll have an increase in their respiratory rate, and this may ultimately result in dyspnea or difficulty breathing. Now, one of the beauties of the infant is that they have a fontanelle, and so this is the window to the brain. In a child who is dehydrated, the fontanelle will be sunken. In addition, their eyes are sunken and they have dark circles. Their skin temperature and color may be abnormal, and they have what we call mottling. So as this child becomes more dehydrated and is more leading towards shock, they have a decreased perfusion to the extremities, and this is exhibited by a pale color, and then they have these red circles, which are the capillary beds. It sort of looks like lace, and that's what we call mottling. And there's also dryness. When you assess an older child, they can have some similarities, but they certainly don't have the fontanelle because remember, that closes by the time the child is 18 months old. So we look at their vital signs. Are they tachypnic? Are they tachycardic? And do they have a fever? Look at their capillary refill. Is it less than 3 seconds or is it delayed and now it's 4, 5, or even 6 seconds? What is their skin turgor like? Is it rapid recoil or is there tenting? You look at their mucous membrane similarly to infants. And then last but not least, do they have decreased urine output? Usually this is reported by the child, but as you know, they're not great historians, and they don't share this information with their parents. So this may not be a good indicator until we as nurses start recording the urine output. So we have dehydration that can go from mild to severe. It can be exhibited as a body weight change, and this weight change is due to fluid loss. The vital signs that will be affected are primarily the heart rate, the respiratory rate, and the blood pressure. Because of dehydration, there's less perfusion to the brain, so there can be alteration of the neurologic status, and this is exhibited in their behavior. They're not doing what they're supposed to be doing based on their developmental age. So as you know, a child's job is to play, run, have fun, go to school, and when they're sick, they're not interested or don't have the ability to do any of this. When we look at the cardiovascular system, there's decrease in the peripheral perfusion. The skin turgor changes. The urine output is diminished, and then our BUN creatinine is skewed. And when you look at this picture, this is what skin tenting looks like. So the first picture that's on the left, you literally are taking the skin on the abdomen, you're pinching it between your fingers, and then when you look at the right, after the fingers are taken away, the skin still sits there, and that's the tent, because it doesn't have adequate fluid to have that recoil. Now this is a very busy slide, but it is an important slide because you need to know this information. This slide came from your textbook. So pay attention to the difference between mild, moderate, and severe dehydration. And the severe form leads to hypovolemic shock. And in this instance, there's a 10% loss in body weight, which means that this child has lost at least 100 mLs per kilo of fluids or even greater. There's a significant increase in the heart rate, and then as the child gets to be in more and more shock, we start losing the heart rate. The blood pressure is reduced due to cardiovascular collapse. There's tachypnea, and then as the shock persists, there may be a decrease in the respiratory rate and then respiratory failure. The neurologic system can be apprehensive initially when it's severe and then rapidly go to lethargy and into coma. Mucous membranes are dry to parched. The fontanelle in the infants is sunken. There's a decrease in the skin turgor. The color of the skin is gray and mottled. It's difficult for you to assess peripheral pulses. So listen to the apical pulse. How bounding is it? And then feel the peripheral pulses. How well is that left ventricle ejecting a volume adequate enough for you to palpate the pulse? The extremities are going to be cold because all of the blood is being shunted to the vital organs, the heart, the liver, the kidneys, and the brain. Cap refill is delayed. There's a significant decrease in the urine output, and eventually there may be no urine output. And then the serum levels of the BUN and creatinine are elevated. This ends part 2 of fluid and electrolytes.